शुक्रवार की शाम डॉक्टर्स के नाम कार्यक्रम में आप सभी का स्वागत है। अब तक हम इस कार्यक्रम के 28 एपिसोड का सफल लाइव प्रसारण कर चुके हैं। आपकी सक्रिय भागीदारी के कारण यह कार्यक्रम 1 लाख से भी ज़्यादा बार देखा गया है। हम उम्मीद करते हैं कि आप इस कार्यक्रम से इसी तरह जुड़े रहेंगे और इसका लाभ उठाएंगे। प्रमुख सचिव चिकित्सा स्वास्थ्य एवं परिवार कल्याण द्वारा दिए गए सुझावों का पालन करते हुए राज्य स्वास्थ्य परिवार कल्याण संस्थान उत्तर प्रदेश द्वारा यूपीटीएसयू के सहयोग से 15 मार्च 2024 से इस कार्यक्रम की शुरुआत की गई है। प्रदेश के कई जाने माने विशेषज्ञों ने स्वास्थ्य के कई महत्वपूर्ण मुद्दों पर लाइव चर्चा की है, जैसे कार्डियोलॉजी, अस्थमा, डायबिटीज़, उच्च जोखिम गर्भावस्था, उच्च रक्तचाप, हेड ट्रॉमा, पार्किंसन रोग, नवजात शिशु देखभाल, श्वसन रोग, डायरिया प्रबंधन, सर्वाइकल कैंसर, संचारी रोग, ओरल हेल्थ, पीलिया रोग, पेप्टिक अल्सर, डेंगू, किडनी स्टोन, अल्जाइमर रोग, हार्ट अटैक आदि। इन महत्वपूर्ण विषयों पर प्रसारित एपिसोड SIHFW के इस चैनल पर कभी भी दोबारा देखे जा सकते हैं, और अगर आप इन विषयों का प्रेजेंटेशन अलग से देखना चाहें तो उसे आप SIHFW उत्तर प्रदेश की वेबसाइट पर पब्लिकेशन सेक्शन में देख सकते हैं। आज कार्यक्रम के 29वें एपिसोड में बच्चों में जन्मजात विकृतियों की पहचान एवं इलाज जैसे महत्वपूर्ण विषय पर आपके साथ लाइव चर्चा करने, इस विषय पर संबंधित सवालों का जवाब देने के लिए हमारे बीच डॉक्टर DG रावत मौजूद हैं। ये आप पीडियाट्रिक सर्जरी विभाग किंग जॉर्ज मेडिकल यूनिवर्सिटी लखनऊ में प्रोफेसर एवं विभागाध्यक्ष के पद पर अपनी सेवाएं दे रहे हैं। आप सभी का कार्यक्रम में स्वागत है। हम राज्य स्वास्थ्य परिवार कल्याण संस्थान की तरफ से प्रोफेसर साहब का स्वागत करना चाहेंगे।
सर धन्यवाद सर। सबसे पहले तो मैं सभी श्रोताओं को नमस्कार करता हूं और मैं आभार प्रकट करता हूं श्री पार्थ सारथी सेन शर्मा साहब, जो प्रिंसिपल सेक्रेटरी मेडिकल हेल्थ एंड फैमिली वेलफेयर उत्तर प्रदेश के हैं। साथ में श्री शिव सहाय अवस्थी साहब, जो डायरेक्टर एडमिनिस्ट्रेशन एंड डायरेक्टर SIHFW हैं। साथ में डॉक्टर महेश नाथ सिंह को, जो असिस्टेंट प्रोफेसर स्टेट इंस्टीट्यूट ऑफ हेल्थ एंड फैमिली वेलफेयर उत्तर प्रदेश हैं। और ये कार्यक्रम जो हो रहा है ये स्वास्थ्य विभाग और राज्य स्वास्थ्य एवं परिवार कल्याण संस्थान उत्तर प्रदेश की पहल पर उत्तर प्रदेश टेक्निकल सपोर्ट यूनिट द्वारा किया जा रहा है। इनको मैं हृदय से आभार प्रकट करता हूं और धन्यवाद देता हूं कि इन्होंने मुझे इस प्रोग्राम में भाग लेने के लिए बुलाया है। श्रोताओं, आज का जो विषय है आप सबको पता है, इसका नाम है कंजेनाइटल बर्थ डिफेक्ट इन चिल्ड्रेन, डायग्नोसिस एंड ट्रीटमेंट। मतलब ये कि जो बच्चे पैदा होते हैं उसमें पैदाइशी क्या डिफेक्ट होता है, उसकी पहचान हम कैसे करें और उसका हम कैसे इलाज करें। मैं डॉक्टर JD रावत, प्रोफेसर एंड हेड डिपार्टमेंट ऑफ पीडियाट्रिक सर्जरी किंग जॉर्ज मेडिकल यूनिवर्सिटी में कार्यरत हूँ। और मैं जो ये बच्चे जन्मजात विकृतियों से पैदा होते हैं उनसे लेकर के 12 साल तक के बच्चों का मैं इलाज करता हूँ। मैं आज जो टॉपिक कर रहा हूँ इसमें क्या क्या कंटेंट हैं उसके बारे में बता दूँ। पहले हम डिफिनीशन की बात करेंगे कि कंजेनाइटल बर्थ डिफेक्ट होता क्या है, क्या क्या इसके इंसिडेंस हैं इंडिया में और ग्लोबल वर्डन इसका क्या है, व्हाट इज द रिस्क फैक्टर एंड etiology ऑफ दिस कंजेनाइटल बर्थ डिफेक्ट and how you can make the diagnosis, what are the classification based on two things, one is medical treatment versus surgical, and they are correctable and by surgery or by medical treatment. And then we also talk about the fetal therapy, which is new in the management of congenital birth defect, and last one is prevention is better than cure. तो हम इस पर बात करेंगे। So, according to WHO, the congenital birth defect is also known as congenital disorder or congenital malformation, and it is said that if the baby born either structural or functional abnormality, they are called as a congenital birth defect. Structural abnormality means there is a developmental anomalies, as you can see in these photographs, that there is a abnormality in the structure, that there is a cleft lip and the cleft palate. And functional abnormality is that baby once born, it's look like a normal baby. You cannot say at that time that baby is abnormal, but with the time, the baby growth and development, or you can say milestone, is not parallel with the normal baby, and then you realize that this baby have some problem, and that is known as a functional abnormality. Now coming to the incidence, the global incidence of this birth defect is around 30 to 70 per 1,000 live birth, and in India it is 2.5 to 4%. And look the overall death in this congenital birth defect, around it is 5 lakh up to the age of 5 years. Every congenital birth defect have a very high mortality rate. So it is nearly 3 lakh children die over a period of 1 year within 28 days by these anomalies, and 1/3 of this patient, that is the 1.7 lakh children, die each year from 1 month to 5 years. So there is a very large population have a congenital birth defect which contribute the infant mortality rate. And 9 of 10 children born with the serious congenital disorder in low and middle income countries. And most common congenital birth defect which we are handling in the department is heart defect and the neural tube. So we will discuss further. And if you look the cause and the risk factor for the development of this birth defect, and 50 to 60% of the cases cause is not known, but rest 30 to 40% cases there is either genetic or chromosomal abnormality, environmental factors, socioeconomic status, maternal infection and maternal nutrition, and maternal exposure to radiation. These causes has been described in relation to the congenital birth defect. Going one by one, the chromosomal abnormality can lead to the development of Down syndromes, Klinefelter syndrome, Turner syndromes, or gene mutation can be either single or polygenic mutations. Consanguinity, that is the blood relation marriage, that can have a very high incidence of congenital birth defect, and certain races especially associated with increased high risk of congenital anomalies due to genetic mutation. So these are the causes has been described in relation to the genetic changes. Then environmental factor, maternal exposure to various pesticides, especially the agricultural, lot of chemicals used in the production of the agricultural things. So if they are exposed much more, they are more prone for developing congenital birth defect. Then medication, especially antifolate, which are like phenytoins and phenothiazines, lithium, diazepam, many drugs has been mentioned, and they are basically antifolic effect, and they are basically, if taken in the early stage of pregnancy, then there is a very high incidence of congenital birth defect. If the mother is taking regular alcohol, tobacco, smoking, these are again lead to the congenital birth defect. High doses of vitamin A, especially in the early pregnancy, high doses of radiation, and the ladies working near or in the waist side, their minds, they are also prone for developing their offspring as a congenital birth defect. Maternal infection is most important, like STD, which is known as a sexually transmitted disease, like tarsus, toxoplasmosis, rubella, cytomegalovirus, herpes virus, and syphilis. HIV, AIDS जिसे हम कहते हैं, they are again responsible for developing birth defect in the children. Hepatitis B and C, varicella zoster, chlamydia trachomatis, gonorrhea, these cases has been seen that they are associated with congenital birth defect. Socioeconomic factors, especially it has been seen that more than 90% severe birth defect occur in middle and low resource countries, and it has also seen that early intrauterine infection and use of alcohol during pregnancy, they are very prone for developing abnormal baby in their children. And another is that advancing age also increases the risk of some chromosomal abnormality, especially the Down syndrome. The maternal nutritional status, like deficiency of iodine, folate deficiency, that is the folic acid deficiency, they are associated with spina bifida, cleft lid. So many things has been described in relation to folic acid deficiency. Obesity, diabetic mother, these are the cases where congenital birth defect are more seen. Environmental chemicals like mercury, lead, zinc, agricultural and industrial chemicals, they are all harmful for mother, and their baby can develop congenital birth defect. Now, how you can diagnose these cases that baby, a developing baby or born baby have some congenital anomalies. So we'll start with antenatal diagnosis and then we'll discuss the postnatal diagnosis. The antenatal diagnosis you can make by doing amniocentesis 14 to 16 week, chorionic biliary sampling, maternal alpha fetoprotein and gonadotropin, ultrasound, aminography, and then fetal blood sampling, fetoscopy and MRI. These are the way you can able to make the early intrauterine diagnosis of congenital malformed baby. And you can also detect chromosomal abnormality, you can also detect neural tube defect, you can also go for soft tissue abnormality or maternal diseases, metabolic and endocrine. All the things can be known by antenatal diagnosis. Then postnatal diagnosis is that the purpose of the postnatal diagnosis is early detection and appropriate management. And you can diagnose by maternal and family history, especially of the previous baby, physical examination, biochemical assess, cytogenic study, blood test, hormonal assess, and radiography if required, and then finally ultrasound. By this way you can able to make the diagnosis in postnatal baby and you can manage accordingly. Now coming to the system-wise involvement, the most common side after cardiac anomalies, we are getting a neural tube defect. That's why I have been starting with the neurosurgery cases first. So the most common thing is the hydrocephalus. Hydrocephalus means there is a collection of fluid into the brain, meaning by there is a collection of CSF. And basically you all know the CSF is formed into the lateral ventricle, third ventricle, fourth ventricle, and circulated and come out by these various foramen into the surface of the brain and spinal cord. So whenever there is a obstruction in the flow of the cerebrospinal fluid, these patients develop a enlargement of the head, and there is a widening of the suture line, there is a bulging of the fontanelle, delayed milestone, bossing, frontal bossing, sunset sign. All the sign you can get in cases of hydrocephalus. And the how you can know the cause of the hydrocephalus, once you will go for the investigation like CT or MRI. But in newborn patient you can go by the ultrasound also. And once you can see here that there is a enlargement of the ventricle, and this patient require some sort of shunt surgery or third ventriculostomy by endoscopy. The another problem is spina bifida occulta or spina bifida cystica. Cystica can be meningocele, meningomyelocele, lipomeningomyelocele, and most of the time it is present on the lumbosacral area, and 70 to 80% they are associated with hydrocephalus. And if it is a severe form, there is a involvement of the lower limb and bladder bowel involvement, and these patients require CT and MRI for screening of the spine as well as for the brain. And you can see here that there is a spine has been become bifid, and here there is a bifid spine, and the spinal content is protruding through this, and that contains basically a meninges as well as the spinal tissue and the nerve which supply to the particular area, and because of that patient may or may not develop neurological deficit depending upon the severity. So these patients require surgical intervention. The another problem in the neurosurgery which we are getting is that is known as encephalocele, either present in the front area, that is nasal encephalocele, or it can be present on the back area, which is known as occipital encephalocele. And these are again containing a meninges with cerebrospinal fluid, sometimes the brain parenchyma, and these cases again require CT and MRI to detect their content, and finally they require surgical intervention depending upon the location of these cases. Now coming to the respiratory tract congenital birth defect, and this group of the patient usually present as a severe respiratory distress syndrome, and this is patient of esophageal stenosis, atresia associated with tracheoesophageal fistula. You can see that this baby have a excessive salivation, regurgitation, choking, coughing and cyanosis at the feeding, and when you try to pass a feeding tube or red rubber catheter from nose or mouth into the stomach, it usually get arrested at 10 centimeter from the oral cavity, and most of the time you can able to make the diagnosis. And this tracheoesophageal fistula are many types, but mostly it is type C type, where the upper pouch is blind and the lower pouch is communicating with the respiratory passage. So these patients usually present as a respiratory distress, and the diagnosis after clinical suspicion, you can take a X-ray in this patient, and you can see the feeding tube or red rubber tube either coiled into the upper pouch, or sometimes it become state if you are putting a red rubber catheter, and then dye usually not indicated, but if you are putting a dye into the upper pouch, it is usually well visualized. So these patients after stabilization require surgical repair by doing thoracotomy, and then mobilization of both the end and primary anastomosis. Now another acute respiratory distress syndrome of the congenital birth defect is that is the diaphragmatic hernia. As you all know, the diaphragm is a membrane which is present between the abdomen and the chest, and separate the content of abdominal versus the chest. But sometimes there is a defect occur into the diaphragm, and that leading to the herniation of the bowel into the chest. You can see here in this patient that this abdomen is squared, and the content of the abdomen has been herniated into the chest, and this patient usually present as a respiratory distress or decreased air entry on the affected side, and there is a squared abdomen. And if you take the X-ray of this patient, you can see here that whole of the abdominal content, that is the bowel, has been shifted to the left side, and this heart has been shifted on the right side. There is a compression of the contralateral lung, and the same times on the same side of the lung is not well developed. So if you have a doubt, you can go by the dye study. You can see the content of the abdomen, that is the bowel, herniated into the chest. So this can be on the right side, most common on the left side, but it can be on the right side. Also here you can see that there is a right-sided diaphragmatic hernia. Whole of the gut content has been shifted into the right side, and it can be either interior, which is known as Margagni hernia, and ultimate treatment is that after stabilizing the patient, you go for surgical correction, and you reduce the content from chest into the abdomen and repair the diaphragm. That is the treatment. Now coming to the gastrointestinal tract congenital defect, and the most common is congenital pyloric stenosis, and it is usually seen in 1 month of male baby, and baby usually have a projectile non-bilious vomiting, and there is a fullness in the epigastrium associated with dehydration. And if you take a plain X-ray, you can get a single bubble shadow into the chest X-ray, abdominal X-ray, like here. And then if you go for the dye study, you can see this stomach is distended, and then there is a string sign, which is known as a classical small passage of dye you can see going into the pyloric area. So this is known as a sting sign. And nowadays the ultrasound is the choice for making the diagnosis. And the ultrasound finding is, if the thickness of the pyloric muscle is more than 4 mm, diameter is more than 14 mm, and length of the pyloric canal is more than 16 centimeter, then this is nothing but a pyloric stenosis. And after stabilizing, these patients require surgical intervention and very simple operation that is known as a seromyotomy, and this is done for the treatment of this patient. Now the another problem is known as a duodenal obstruction. These group of the patient is also have a recurrent vomiting, but this vomiting is a bilious instead of non-bilious as in cases of pyloric stenosis, and upper abdominal fullness is same like a pyloric stenosis and associated with dehydration, electrolyte disbalance. The pyloric stenosis cases usually present little late after 1 month onward, but here the baby usually present within 24-48 hours. That is the difference. And if you go for the X-ray in this patient, you can get a double bubble shadow, as in this case stomach is distended and going up to the first part of the duodenum is well visualized. And if you go for the dye study, you can see the stomach is grossly distended and it is the duodenum is also distended. So after stabilization, this patient again require for surgical intervention. Now coming to the small bowel obstruction, especially the jejunal and ileal atresia, where you can see the baby that it is have a distended abdomen, and you can see the visible peristalsis here. You can see the visible peristalsis in this patient. And what is happening in this patient is that the atresia means non-canalization of bowel. So you can see the photograph of this patient that this proximal bowel is grossly distended and there is a obstruction here or atretic segment of the bowel, and there is a normal looking bowel. So these are the usual finding in the small bowel atresia. And if you go for the X-ray of this patient, you can get a multiple air fluid level which is indicative of the jejunal, or the more fluid level is ileal atresia. So the diagnosis is based on the examination and the this X-ray finding, and you can stabilize the patient and go for the surgical intervention, which usually require resection and anastomosis of the bowel for the correction of this problem. Another congenital birth defect which we are getting in pediatric patient is that is the Hirschsprung disease. This is also known as aganglionosis of the colon. Especially it start from the rectum and it ascend upward. So these group of the patient usually present as a recurrent constipation since birth. As we all know, the newborn patient usually pass meconium in first 24 hours and very few up to 48 hours. And this group of the patient usually pass meconium after 48 hours. So they have a typical history, and there is a abdominal distension and failure to thrive. And if you pass some flat tube parectally or do the parectal examination, you will get a gus of the flatus and feces and abdomen become scapular. So this is the usual story on examination in this patient. And if you do the plain X-ray in this patient, you can see there is a distended colon and there is no gas into the pelvis. And if you go for the barium enema examination, you can see the dilated colon, then there is a tapering, and there is a collapse segment. So this is the classical finding in the Hirschsprung disease. This is known as a just like a dilated and tapering. So this is the transition zone, and this is the portion where ganglion cells are absent, and this tapering zone having a hypoganglionic cells, and the dilated segment is a normal ganglionic segment. So in this patient, again, we stabilize the patient depending upon the general condition. Either we can go for the colostomy initially, and once the baby will improve, then we'll go for the definitive surgery. Otherwise, if the patient is otherwise well and you have managed the patient nicely, then you can go for the primary repair means excision of aganglionic segment per rectally and excise the aganglionic segment and anastomose with the ganglionic segment. So these are the cases of Hirschsprung disease of the management, and this is one who require lot of management in terms of pre-surgical resuscitation, bowel preparation, and then surgical intervention. Then another congenital problem which we are looking in newborn or older children is that is the congenital band into the abdomen, and this band is nothing but a patent vitellointestinal duct which are present, and this baby present as a intestinal obstruction. You can see there is a dilated bowel. So once you stabilize the patient, go for X-ray, you will get a multiple air fluid level, and then after exploration you see the band and divide, and most of the time it's become otherwise well. Then another problem which we are getting in abdomen is that is the mesenteric cyst, and this mesenteric cyst can be usually lymphatic cyst or chylolymphatic cyst. You can see the color of this this bowel cyst is that here it is a clear fluid, but here it is a somewhat creamy and it is a somewhat milky. So different type of mesenteric cyst they are present, either mesenteric border or anti-mesenteric border, and they usually present as a intestinal obstruction, and on exploration you have to either take out the cyst, or if it is small then you can enucleate it. Then another group of the patient have a congenital anomalies is the imperforate anus, or it is called as a anorectal malformation. This is the large group of the patient which we are receiving in the department. In this case you can see that there is no opening into the perineum, that is meaning anal opening is absent, or in the female baby opening may be absent at normal place or may present somewhere interior between the just behind the vagina, or sometimes there is no opening at all into the female baby also, and sometimes you can get a small tract going up to the scrotum and there is no opening in the perineum. So they are different type of presentation. So the diagnosis is usually made by history, examination, and then finally we go for the X-ray. There is a X-ray which is known as a invertogram, or it is known as a prone cross table lateral X-ray, which is usually done after 18 to 24 hours after birth, and so that the gas will reach into the bottom of the perineum, and once the baby you take the X-ray, you can see the gas is coming up to this level, and this seems to be the very high type of anorectal malformation. In such situation you can go for the initial colostomy, but if this gas shadow is going very close to this radio opaque shadow, it means it can be corrected from below. So it is basically low type of anorectal malformation. So single stage surgery is required in these cases. The another problem is known as a Michel's diverticulum. This Michel's diverticulum is a basically remnant of the vitellointestinal duct, which is just looking like a appendix. It is usually present in 2% population and 2 feet away from ileocecal junction and roughly 2 inches long, having 2 to 3 type of epithelium, that is the intestinal epithelium, pancreatic tissue, then have a gastric tissue. So because of this, these patients have recurrent diverticulitis, means pain, vomiting, and presence of gastric mucosa, there is a bleeding, so patient may present as a bleeding per rectum, and diagnosis is usually made by history and examination, and the Michel's scan is the most important diagnostic tool for knowing the this Michel's scan, and they can present as a intestinal perforation, intussusception. So various way of presentation, and once it is diagnosed, and the treatment is surgical excision and the into anastomosis. The another problem of gastrointestinal tract in the birth defect is umbilical hernia. You can see here there is a small umbilical hernia. Here you can looking is a very large umbilical hernia. Both the cases they usually present at the area of the umbilicus, and it is well covered with the skin. That is the good thing. And if it is small in size, it will usually close spontaneously, no treatment is required. But if it is large, like this case, or here you can see this is more than 2 centimeter, then this group of the patient require surgical correction. The another problem swelling around the umbilicus is known as the examphilas. You can see here there is a herniation of the bowel along with the liver, and almost all content of the abdomen is herniated through the umbilicus. And you can see here there is a thin transparent membrane which are covering this swelling, and this is known as the examphilas. Depending upon the size of this protrusion, it is known as a minor or major. So you can see this major type, this is a small minor types. So both are basically examphilas. But here you can see that there is no covering at all of the membrane, and the bowel is out from the umbilicus, and they are hanging, they are edematous, they are foreshortened. These group of the patient, in fact, have a very high mortality because there is a very prone for the sepsis. So in this group of the patient, initial treatment is that you have to put patient on conservative management. You just protect this, and with period of time there is epithelialization of the skin occur over this swelling, and then slowly the abdominal cavity will grow, and later on you can repair like a incisional hernia in this patient. But here the mortality is very high because of the exposure of the bowel. So even if you are closing this and putting the things into abdomen, these patients require ventilatory support in the post-operative period. So this is the way of management in this patient. Then coming to the another congenital birth defect in children, that is the inguinoscrotal swelling. This swelling can be either inguinal or can be go up to the scrotal area, or can be vice versa, and they usually present as a swelling usually few months after birth. So these are basically they containing the bowel or sometimes omentum, and you can see here there is a large hernia as compared to this one. This is the small baby. So in this group of the patient, early indication for surgical intervention, because compared to the adult hernia is a bigger, and they have no usually have a less chances of obstruction as compared to the pediatric patient. But in pediatric patient, the ring size is small, and the very high incidence of obstruction, strangulation, and then gangrene of the bowel along with the same side of the testis. So once you have diagnosed a case of inguinal hernia, there is no time when to go operate. As early as possible, patient go for surgical intervention. The another congenital anomalies which we are looking in the hepatobiliary system is choledochal cyst, where the baby present as a obstructive jaundice or lump in upper abdomen, and history of clay color stool, or history of recurrent pain and cholangitis, especially in the upper abdomen. And the diagnosis is based either ultrasound or MRCP, and the treatment in this case is excision. The another things in hepatobiliary is the biliary atresia, where the extrahepatic bile duct is not developed along with the intrahepatic bile duct also. So that group of the patient usually present since birth, but it takes at least month, 2 months for making diagnosis, and in that situation the diagnosis is based on the ultrasound, where that will show there is no extrahepatic bile duct, gallbladder is absent. And then if you go for the HIDA scan, nuclear scan, then you can see that there is excretion of dye is not going from the liver into the duodenum, you can make the diagnosis. So these two are the most common congenital birth defect in hepatobiliary. And in fact, biliary atresia, if it is come early, you can go for surgical intervention like portoenterostomy or so-called Kasai operation. But if it is coming late after 3 months or 4 months, they usually have a cirrhotic liver, ascites, development of portal hypertension. In that group of the patient, they are require hepatic liver transplantation. Now coming to urological problem, that is the hypospadias. In hypospadias, the urethral opening are present on the ventral aspect of the penis instead of the glans. So this can be from the corona up to the perineal area. So there are different type of hypospadias, and they may associated with cardi also. So usual time for operation in this patient is usually 1 to 3 years. And there is either you can go for the single stage or double stage depending upon the anatomy of the hypospadias. The another urological problem is opposite to the hypospadias is epispadias, where urethral opening present on the dorsal aspect of the penis instead of ventral aspect. And they are again different type like coronal glandular epispadias or penile epispadias. It can be severe associated with extrophy epispadias complex. This is the glandular epispadias, and they are also associated with cardi, but this cardi is on the dorsal aspect instead of the ventral aspect like in hypospadias. So treatment again is either single or two-stage correction and urethroplasty, and these are the cases usually come little late. Now coming to the another very complex urological problem, that is the extrophy epispadias complex. As I told you, epispadias can be associated with extrophy. So this is the cases where you can see there is a large, bladder is completely open here, and both the ureteric orifices you can see in very close observation, and the continuous dribbling of the urine. There is a epispadias. So this can be either in the male baby or can be in the female baby. So most of the time it require a stage operation, or sometimes if the good bladder patch is there and patient is otherwise stable, you can go for the single stage repair like here. And the usual problem in this patient is continence, but if you are going stage by or even single stage, the continence will return with period of time. The another problem in the urological is that is the bladder outlet obstruction. Means the patient baby is not able to pass urine properly. Either it is passing with very difficulty, or straining during maturation, or have a very poor urinary stream, or have a recurrent urinary tract infection and failure to thrive. So these group of the patient, if you go for ultrasound, you will get a bilateral hydroureteronephrosis and thickening of the bladder. And if you go for the dye study, as you can see here, this is known as a MCU, micturating cystohystogram, you can nicely see the bladder which is trabeculated, and there is a dilated posterior urethra which indicate there is a flingy valve into the posterior urethra. That is the cause of the obstruction. This is the most common, but sometimes if it is not there, the another cause of the bladder outlet obstruction in the interior urethral valve or diverticula. You can see the interior urethra is dilated, and this is acting as a valve, and that patient present as a bladder outlet obstruction in this patient. So they usually require endoscopic fulguration of this case, and here usually require surgical correction by open method. The another cause of the bladder outlet obstruction is bladder diverticula. You can nicely see it seems to be double urinary bladder, right? And there is a reflux on the right side, left side also. So in the lateral view, you can nicely see this is the bladder here, and there is a diverticula, and this ureter is opening into the diverticula. This is known as a Hutch diverticula, and this group of the patient again present as a bladder outlet obstruction, because this diverticula is compressing to the bladder neck, and patient may present as a bladder outlet obstruction. So in treatment in these cases, after stabilization, you have to go for excision of the diverticulum and the ureteric reimplantation depending upon the type of diverticula. The another urological problem is hydronephrosis, usually PUJ obstruction, means pelvic-ureteric junction obstruction. Baby usually present as a lump, as you can see, as a large lump here, and then may present as a recurrent urinary tract infection, sometimes hematuria. And if you go for the dye study, as in this case, there is a IVU showing dilated pelvic calyceal system on the left side. And if you go for the renal scan, you can know the differential renal function, then you can get the renal function, and accordingly you can plan for the surgical intervention. This is the another patient, this is the same patient of hydronephrosis. So after diagnosing this patient of hydronephrosis due to PUJ obstruction, this is the operation which is known as a pyeloplasty, reduction pyeloplasty. If it is large pelvis is there, and if it is not, then you can simply excise and do the pyeloplasty. The another urological problem which is very common, which is known as undescended testis. As you all know that both the testis should be in the scrotum, but sometimes what happens, the testis, one testis or sometimes both the testis may not be in the scrotum, and that is known as undescended testis. And baby usually present as a absent testis in the scrotum. And if you examine this patient, you will get a empty scrotum with poor development of the scrotum, and this testis can be arrested into the either in the abdomen or in the inguinal area. Sometimes this testis may become ectopic. They can be present in the perineal area, they can be present in the thigh, they can be present in the contralateral side. So these are the unusual location of the undescended testis, and these undescended testis sometimes associated with clinical inguinal hernia. Although the patent process vaginalis are present around 80 to 90% cases of undescended testis, but clinical hernia present in few patients. So the ideal time of the treatment of this patient is as early as possible, means between 6 months to 1 year this patient should be operated, because testis which is present higher, they are associated with lot of complication, hard body temperature, they are not fixed, so they can go under testicular torsion, or sometimes they can have a recurrent epididymoarchitis. There is a lot of psychological trauma to the parent and patient that their testis not in the scrotum, and sometimes this testis go testicular torsion, to testis become totally gangrenous. So if the patient you have diagnosed at the age of 6 months, 1 year, you should go for orchidopexy. The diagnosis of undescended testis is made by clinical examination as well as supported by ultrasound. If the test is not palpable, then the best investigation is go for the laparoscopy, endoscopy. You can put the laparoscope in and you can see sometimes testis is present into the pelvis, or you can mobilize and bring it to the scrotum. Now coming to the another rare problem, congenital problem in the female baby, is that there is a absent vagina and sometimes imperforateness, and here in both the cases you can see here that the vagina is absent, and sometimes there may be associated absent of the uterus, and this is known as a MRKS syndrome. So later on this patient require vaginal reconstruction either by skin grafting or by the bowel. Or here in the right side you can see that there is a bulging of the fluid, and this is the imperforate hymen, and this is the collection of the fluid into the vagina. So this is the simple way of management. Just give a incision and the fluid will drain and it's become otherwise normal. Now coming to the musculoskeletal anomalies, and lot of club foot you have seen in their OPD or in your relative or some children, and these are different type. That can be Barrett's deformity, that can be Quinus deformity, that can be bulgus deformity. So these group of the patient initially go for the conservative management, basically physiotherapy, and the plasters are required, and later on if patient coming too late, then some sort of MRI is required and surgical intervention to correct this deformity. Then congenital dislocation of the hip, this is also present since birth, and this patient have a abnormal position of the lower limb, and they are diagnosed by the clinical as well as by X-ray, and then require either plaster and sometimes require surgical intervention. Then polydactyly, you can the accessory finger usually present into the little attached to the little finger, but sometimes they are present into the thumb also. So depending upon the this location, they are usually require surgical intervention. Sometimes you can get a waving finger where both the fingers are fused each other. So these again require surgical intervention by X-ray and all the things. The another very complex problem is that is the amelia or fecomelia, where the upper limb or lower limb is not developed properly, and this group of the patient is require lot of attention for their management, because we have not seen such a patient in routinely, but I have seen somewhere in the pictures where these peoples are kept for public as a collecting money. So this can be happen, and one of the drug which was initially blamed for this is thalidomide, which is nowadays not used, but this anomalies can be happen. Then coming to endocrine abnormality, this endocrine abnormality is one is the congenital hypopituitarism, and this is you can see this very complex problem, and managing this patient is very challenging. They are basically require lot of medical treatment. And then congenital goiter, if the female is regularly or have a hypothyroidism during pregnancy or not taking proper treatment, their children, their baby can have a congenital goiter like in this patient. Then coming to some common and miscellaneous is that tongue tie. You have all seen that normally tongue is attached to the base of the oral cavity, but sometimes the tip of the tongue is attached at the close to the lower alveolus. So baby is not able to protrude their tongue out from the lower lip. So this is known as a tongue tie, and they are usually require some release operations. Then cleft lip, you have all seen the cleft lip, and cleft lip usually if it is diagnosed very early, because once the baby is born, cleft lip is usually visible. So usual time for cleft lip repair operation is 3 to 6 months, and it can be unilateral or can be bilateral. Then cleft palate, you can see there is a cleft in the palate, and in cleft palate there is a problem of regurgitation of milk or fluid from the nose. There is a recurrent otitis media. So once it is diagnosed, it require early surgical intervention. Then this is the another group of the patient which is known as a hemangioma, and you can see variety of hemangiomatous lesion has been described. We are looking in there our patient in OPD. So it can be present on the nose, leg area, perineal area, face area, anywhere can be present. And this is difficult cases where management needs some sort of multidisciplinary approach, and some of the juvenile hemangioma usually get disappear with period of time, but those who are associated with AV malformation, arteriovenous communication, they require embolization or sometimes laser surgery to correct them. Then coming to the another problem is known as a cystic hygroma, as its name is. Hygro means watery, is a cavity containing fluid, and this is basically lymphatic malformation, and they can present anywhere in the abdomen, in the body. The most common site is the neck, followed by the axilla, and the diagnosis is made by the clinical as well as supported by the ultrasound, and the treatment is conservative, and if conservative failed, then surgical intervention is required. In conservative, we are using the aspiration and putting the sclerosing agent. Either we are using 3N saline, or we are using the boiling water, or we can use the bleomycin. We are also using OK432. So there are different sclerosants that can be used for treatment of these cases. Now another problem is that is known as a teratoma. Teratoma is nothing but a totipotent cell, and they are usually present into the sacral area because they are starting from there. So this is this site of sacrococcygeal teratoma is the most common site, and may be present as a mass, and this mass is usually displacing the perineal structure like rectum, urethra away, and patient may present as a, apart from mass, as a intestinal obstruction due to compression over the rectum or bladder outlet obstruction. So after investigation, this patient requires surgical intervention, and the teratoma can be present other part of the body. You can see a large teratoma which is arising from the base of the tongue. They can be present from the neck, can be. So these are the cases which are rare, but they are present since birth, and they are considered as a congenital birth defect. Then macroglossia. Macroglossia is again a congenital birth defect of the tongue. You can see a large tongue which are coming from the oral cavity. So this can be because of the lymphangioma or some mass into the tongue, and if it is a cystic lymphangioma of the tongue, simple treatment is that you can do the aspiration and sclerosing agent like cystic hygroma. But if it is other than that, then it requires reduction glossoplasty. Now conjoined twin, although rare but can happen, and we have operated conjoined twin. Both the twins are otherwise well. They can be attached with the thorax as well as the abdomen, is known as thoraco-omphalophagus, or can be craniopagus, can be ischiopagus, and can be partial or can be complete. And this left side, you can say right side, this is the, this one is the partial way. You can see it is attached with the pubic bone. So these are the congenital twin. Have a very complex problem. Sometimes they have a this heart common, sometimes the liver common, sometimes when they are attached with the cranium they have a brain common. So depending upon their anatomy, these require separation and further treatment. Now coming to the congenital heart diseases, they are very common. I think this is one of the most common other than other congenital birth defect, and most of the mortality in the surgical baby is because of the congenital heart diseases. And you can see there is a VSD, can be ASD, can be PDA, coarctation of aorta, transposition of great vessels, tricuspid atresia, aortic stenosis, tetralogy of Fallot. So many things has been described, and they can be cyanotic heart disease, can be acyanotic disease. So if the patient have a congenital heart disease along with the other problems like GI, urological, so overall mortality is quite high. So these group of the patient is treated first by this cardiac defect by cardiac surgeon, and then you can go for the other surgical intervention so that mortality can be reduced. Then coming to the blood disorder, certain blood disorder where baby present as a anemia like thalassemia or sickle cell anemia, congenital spherocytosis, where these problems occurring into the RBC and this group of the patient usually present as a anemia, so their treatment is according to the etiology. Hemophilia, as we all know, there can be hemophilia A, hemophilia B, and where the bleedings, there is a problem of clotting and bleeding problems. So these patients, once trauma is occurred, there is a continuous bleeding and clot is not formed. So you have to give some sort of that factor 9 deficiency, factor 8 deficiency for the treatment of these cases. Then certain metabolic disorder, they are also present congenitally. As I told you, कि baby born otherwise looking normal, but with period of time their milestone or their growth and development is not like a normal baby. So these baby usually have some of the metabolic problem like cystic fibrosis, G6PD deficiency, phenylketonuria, congenital lactose intolerance, glycogen storage diseases, Wilson diseases. So these are the cases. They are diagnosed very late, and then once diagnosed, they are treated medically. Now coming to the fetal therapy. Now the advancement of medical field, especially in pediatric surgical cases, the fetal therapy has been now, fetal therapy and fetal surgery is coming up. And normally if the baby having anemia in the intrauterine period, then we can go for the fetal blood transfusion. And if the patient having hypothyroidism, baby having hypothyroidism or adrenal hyperplasia, then we can treat medically. And certain fetal surgery has been started either by endoscopic or by the open surgery, especially for the congenital diaphragmatic hernia, where gut is herniated into the chest, and because herniation of gut into the chest, same side of the lung is not developed. So there is a compression of the heart as well as to the contralateral lung. These group of the patient require early sort of the intervention for development of the lung. So either go for the endoscopic procedure or you can go by the open procedure. The hydrocephalus, as I told in the beginning, there is an enlargement of the head due to poor drainage or obstruction in the outflow of the CSF pathway. So in that cases, you have to put the shunt in the intrauterine period so that the brain will develop, and later on, once the baby will born, you can take care of the shunt later on. The bladder outlet obstruction. In bladder outlet obstruction, both the ureter and kidney become grossly dilated, and there is a renal hypoplasia or dysplasia occur. So if the baby of the bladder outlet obstruction diagnosed early, especially in the middle 15 to 20 week of gestation, then you think for draining the pressure of the bladder into the amniotic fluid by putting a shunt, so that the kidney will grow and the amniotic fluid will also become sufficient, and there is a growth of the lung and baby, and then later on you can manage this patient. Then stem cell transplantation and gene therapy. This is again a very important step in the management of congenital anomalies in the baby who have a genetic problem, especially before 18 weeks, because in this period of time the baby immunological things are not very well developed. So if you are treating this baby before 18 weeks, the immunological reactions related to the treatment will not take place, and result is almost good in these cases. Now coming to the prevention. Prevention, you know, is better than cure. So how you prevent the congenital birth defect? As I told in the beginning, the causes you know about the congenital birth defect that you can treat by avoiding these causes. And so you discourage consanguineous marriage, especially blood relations, where one disease can transmit it to the another in the baby. This is the most common thing, so you avoid this or discourage is. Avoid late marriage and pregnancy. As I told you, late marriage over 35, more baby have a born which having congenital chromosomal abnormality like Down syndrome and others. Promotion of health of the good child and pregnant health status of the female by prevention of malnutrition, anemia, aiding of the folic acid, so iron, all these things should be taken care when the baby is otherwise to the mother, so that baby born will not suffer with congenital birth defect. You encourage the immunization of all female child by MMR, which are responsible for various congenital anomalies, mumps, rubella, mumps, measles and rubella vaccine, which is most common for the cardiac congenital anomalies. Then protection of individual and whole community against the mutagens like exposure to radiation and drugs which are responsible for the development of congenital birth defect must be restricted or should not be taken without advice of the doctor. And the smoking, alcohol should not be taken during and before pregnancy, because these are the things where the congenital birth defect are more common. Immunization by anti-D immunoglobulin to the Rh negative mother after abortion for development of problem congenital birth defect in their baby. Elimination of active and passive smoking and tobacco to the mother. Avoid of drug intake without consulting physician in the first trimester. You know, the first trimester of the pregnancy is the most important, especially this is the time where there is a organogenesis. So most of the insult to the developing baby is occurring in this period, and the baby who having the spina bifida in the previous baby, their mother should take at least folic acid 400 1 month, 2 month before conception, and it should be continue at least for 6 months to avoid development of spina bifida in their next baby. So this is the important prevention of intrauterine infection and promotion of sexual hygiene. So as I told you, intrauterine infections like sexually transmitted like Tarchet infection, mumps, rubella, syphilis, AIDS, all can be preventable, and they can be prevented. If it is prevented, chances of congenital and other birth defect are very less. Then efficient antenatal care. If the mother is pregnant, it should be always with the antenatal clinic by good gynecologists, so that there should be good monitoring of their baby. Promotion of therapeutic abortion after prenatal diagnosis. Discourage reproduction after birth of baby with congenital anomalies. If the one baby is born with congenital anomalies, chances in the subsequent baby is very high. So you have to watch this baby and take a good antenatal care. But if this next baby is developing the same problem, then we have to conscious and think for reproduction of the another baby. Increasing public awareness about the risk factor and etiological factor of the congenital anomalies and their preventive measures. So these are the tips for the prevention. You must think for this, and I think we are continue with our presentation and discussion. So in congenital birth defect baby, who is born early and it is diagnosed, is the most important thing is that you have to stabilize the baby. And stabilization means you have to maintain the temperature, you have maintained the hydration, you have maintained the fluid and electrolyte. Because what we have seen, that patient who is born in the rural area coming to the our center, it is too late to reach in our center, number one. Number two things is, if they are coming, they are associated with lot of problems, as I told you, temperature problems and the fluid electrolyte disbalance, so and associated with infection. So once this congenital birth defect baby is diagnosed, you have to send at tertiary care center as early as possible with good care in terms of maintaining the temperature by putting a carton around the baby so that their temperature maintain, especially the winter season. And you have to give the fluid by IV and push the nasogastric if the abdomen is distended, so that the abdomen get become less distended and the gases will come out, and there is no compression of the diaphragm leading to respiratory compromise. And if possible, you support by giving the oxygen and transfer to the center where the facility of surgical intervention is required. Thank you very much for patience hearing, and any query, most welcome.